Hello, good morning, everyone. So we'll start. So today we'll be discussing a case of a 43-year-old female who's a homemaker and resident of Karoli, Rajasthan. She came with chief complaints of black colored stool since the last 15 days, multiple episodes with associated with periumbilical pain for the last 15 days, and progressive generalized weakness for the last 10 days. On elaborating history, uh, patient.
So, so if you have this history presenting complaints, what comes to your mind?
Sir, from the brief history that is the presenting complaints, we can come to a conclusion that she probably has some gastrointestinal bleed, which is manifesting as melena over the last 15 days, and definitely looks like some sort of a pathology in the abdomen because it is associated with pain as well. And the bleeding is ongoing and persistent as her weakness is now progressive. So definitely we can come to a conclusion that there's a gastrointestinal bleed which is significant, causing her manifesting as weakness for this particular individual.
So you said that you thought of GI bleed, and then you said probably the problem is in the abdomen. GI is not part of
No,
the abdomen.
GI, what I basically
No
bowel.
need to
Yeah,
say that.
yeah,
So it is basically GI bleed.
yeah.
Can you be more specific?
Sir, it is an upper GI bleed, sir.
Upper GI. Why do you say that?
Sir, because it is manifesting as melena. A lower GI bleed may manifest as darkish discoloration, but more likely it will be more fresh. It will more have it will not be black. It will definitely have a reddish hue or a tinge to it, sir, compared to a UGI bleed, sir.
So melena is a technical term. We interpret it as melena. How does the patient describe it?
So black tarry stool.
What do you mean by tari?
Means it will have this sort of a not it will stick to the pan.
Sticky.
Yeah.
Sticky stool. So depending on what toilet the patient is using, if it is a Western toilet, it may not be easy to appreciate.
Yes,
It's more easy to appreciate in an Indian toilet where the stool sticks to the pan. Okay. So you said that upper GI. What is the definition of upper GI bleed?
Sir, upper GI bleed anatomically will be a bleed proximal to the attachment of the ligament of teeth, the suspensory ligament of teeth. Anything which is proximal to it will be considered an upper GI bleed, sir.
So melena means only upper GI bleed?
No, sir, not just upper GI. If the transit of across the bowel takes a longer time, it may eventually manifest as melena. And upper GI bleed may also manifest as hematochezia if it is a large volume sudden bleed, sir.
So the two are not synonyms.
Yes.
Mostly upper GI bleed results in melena. But as you rightly said, if it is a large upper GI bleed, for example, peptic ulcer which is bleeding, patient can present with hematochezia because blood in the bowel causes hyperperistalsis. And the transit time is not enough for the blood to get chemically denatured and discolored. The patient can, that is why in every patient with lower GI bleed, an upper GI endoscopy is a must, number one. And all units will have a case where if you didn't do an upper GI endoscopy, you missed a peptic ulcer or an upper GI ulcer. Second, reverse. Melena does not necessarily mean the upper GI bleed, because even small bowel bleed, which technically and semantically is lower GI bleed, presents with melena, isn't it? So the two are not synonymous. Okay. So you think it is GI bleed and you think it is upper GI.
Upper GI.
So you think it is upper GI bleed proximal to the TJ?
Sir, that is difficult to say at this point, sir.
What is her next symptom?
Periumbilical pain.
What
So
is that?
small bowel pain pathology usually manifests as
So there is a
periumbilical.
hint there
Yes.
that she doesn't have epigastric pain.
Yes.
She doesn't have upper abdominal pain. She has periumbilical
Also, sir,
pain.
another point in favor of probably a small bowel pathology is that she has not had any episode of hematemesis.
So in duodenal peptic ulcer, you may not have
any
hematemesis at all.
isn't it? Yes.
If the pylorus is intact, she is a young lady, pylorus is competent, patient may not have.
Yes.
But yes, it
Just
is a
another
soft
indicator.
Point. It is a soft point.
Yes.
So most likely, based on this history, you can say that it is GI bleed. It is from melena upper GI, but from the pain it looks more like a small bowel bleed, which technically is not upper GI bleed,
but
and
manifests
the
as
bleed
melena.
is continuing, and it is significant because it is now causing symptoms related to anemia.
Anemias. So,
And the likely pathology, so that is the site of bleeding. Likely pathology,
pardon me, sir.
likely pathology.
Sir, most likely a small bowel. It can be
वो
a
तो
small.
site हो गया ना. What is the pathology?
Most common small bowel bleeds is because of angiodysplasia, sir.
Most common cause of small bowel bleed is angiodysplasia.
Yes, sir.
Which is the commonest site where angiodysplasia are
The
right colon, cecum and right colon. Small bowel, what is the commonest site of bleeding? Commonest cause of bleeding. Suppose this patient had history of continuous fever for last 2
ulcerations
days.
they can be enteritis or ulcerations, typhoid enteritis. They may slough off and bleed.
Typhoid, if you take all patients with small bowel bleed, still probably typhoid would be the commonest. But here that is unlikely because there is no history of fever. So you can't make a clinical diagnosis of typhoid. What else will cause enteritis and ulceration? Which is the other common disease of small bowel in
Sir,
our.
We have inflammatory bowel disease, which may
Like
Crohn's.
Something more common than Crohn's. Tuberculosis. What is our national disease?
Tuberculosis.
Can tuberculosis cause small bowel bleeding?
It can, sir.
So terminal tuberculosis is classified into gastrointestinal, peritoneal, and lymph node. Gastrointestinal is then classified into, in order of frequency of involvement, terminal ileum, ileocecal area, right colon, jejunum, colon, then esophagus, stomach, duodenum, okay. So out of and then in tuberculosis, the pathology can be ulcerative, it can be hypertrophic, and then it can be stricturing. These are the three common types of pathology. It can be a combination. It could be ulcero-hypertrophic, it could be ulcero-stricturing. So the ulcerative type of GI tuberculosis, the presentation is with bleeding, but it is also associated with diarrhea. So now we will see what is her stool frequency. If her stool frequency also has increased, then it could be that she has ulcerative type of GI tuberculosis, for which the commonest site is terminal ileum, which can present as melena. And then it could be any non-specific enteritis, any drug-induced, any food poisoning which can cause enteritis. So those are the other. Yes.
So looking further on elaborating her history, sir. So she gives a history of passage of black-colored stools for the last 15 days associated with pain in the periumbilical region. The stool frequency is about 2 to 3 times a day. So this stool frequency has increased ever since she has started complaining of this black passage of stools. The pain is sudden is in onset. Usually it precedes her bowel movement and it is moderate in intensity, continuous, non-radiating, and was relieved on taking over-the-counter medication, which she took for a period of 3 to 4 days. Over the next 5 days, the patient developed generalized weakness and lightheadedness. Initially, sir, she said that it was difficult for her to get up while lying down during these episodes, but over the last 2 to 3 days, she's saying that she's even feeling weak and lightheaded even at lying down in supine position. So there is also a history of unquantified weight loss in the last 15 days. So for these very same complaints, the patient got admitted at our institute on the 18th of this month, and following which she was evaluated biochemically and was found to have a low hemoglobin, and she had consecutive 5 units of transfusion since admission, sir. Uh,
Hemoglobin is not a biochemical investigation, it's a hematological.
Hematological. So there is no history of jaundice, abdominal distension, altered sensorium, vomiting, fever, hematemesis, bleeding from any other sites, uh, any history of altered bowel or bladder habits before this episode, no history of long-term NSAIDs, antiplatelets, anticoagulants, or steroid intake. There is no previous history of any endoscopic intervention, No history of blood transfusion prior to this admission, and no history of any abdominal trauma.
This list of negative history, which are the more important ones?
Sir,
is jaundice the most important?
Sir, upper GI bleed can be classified into variceal and non-variceal. So by taking the history of jaundice, abdominal distension, altered sensorium, and bleeding from other side, we are trying to rule out the liver part so that the variceal bleed can be excluded. And the most common cause of UGI bleed is peptic ulcer disease. And since she does not have any history of epigastric burning or NSAID intake,
the commonest cause of GI bleed still would remain peptic ulcer.
Yes, sir.
That should have come first. Number one. Number two, hematemesis is important. So drug history, some students will put in the drug history, but if you have put it here, that is more important, right, rather than the other symptoms. So even negative history, when you are presenting a list, it should usually be in order of importance, in order of statistical significance.
Right. So with this negative history, we've been able to rule out the peptic ulcer and the variceal component, which forms the majority of the causes of the upper GI bleed, sir, in most of the patients. Sir, as we took more elaborative history, sir, so there was this significant history where this patient says that since the year 2003, she is having constant right upper quadrant pain, and that pain was dull aching in nature, was usually relieved on taking over the counter analgesics. However, since the pain was persistent, she was evaluated in the form of ultrasound abdomen multiple times and in the form of blood investigations. She says that in the year 2000, the end of 2003, she underwent a needle biopsy. We are not sure if it was a biopsy or just a fine needle aspiration. And she was told on her ultrasonological evaluation that there was a lesion in the liver from which she underwent this biopsy. From discussion, she said that the doctor that she had consulted told her that it was a benign lesion and that she had nothing to worry about it, sir.
You think was the most likely diagnosis?
Sir, most likely a hemangioma, sir.
Although you yourself would not put in a needle in a hemangioma, but that is what happens in the real life. That as soon as a space-occupying lesion is seen in the liver, yes, people do put in a needle without giving consideration to the fact that it could be a hemangioma. And the commonest overall space-occupying lesion of the liver is hemangioma. Commonest benign lesion of the liver is hemangioma.
So looking to her past history, sir, there is she does not have any comorbidities or any significant surgical history. She consumes a predominantly vegetarian diet, no addiction. Prior to this, her bowel bladder habits were regular. And sir, recently, over the last 10 odd days, she's saying her appetite is reduced. She says there's a feeling of postprandial fullness. Other than that, sir, the family history is not contributory, and then her menstrual and obstetric history is also unremarkable, sir. So coming to a brief summary of what we have understood till now, she's a 43-year-old female.
Summary is always brief.
Yes, sir. Sir, 43-year-old female presented with melena, periumbilical abdominal pain, and generalized weakness and quantifiable weight loss for 10 days, and a long-standing liver mass for about 20 years.
So you said she is now passing 2 to 3 stools per day.
Yes,
is that her normal stool frequency, or is there a change?
There has been a change, sir.
So that is important.
Yes.
That again indicates that some inflammatory or ulcerative disease of the small bowel probably is happening.
Yes. So looking to a general examination, patient conscious.
And you did mention about lightheartedness and weakness and the fact that when she got up. But so all these indicate severe anemia.
Sir.
So you should describe the symptoms of anemia in more detail. What else you should have asked and mentioned? What are the other symptoms of severe anemia?
Sir, she can have peripheral edema, sir. They can be.
That comes much later. Okay. Before that, she's a homemaker. She must be doing her routine
general
job.
Tiredness, like
dyspnea.
Yes.
If she has a flight of stairs at home, she can't go up on the rooftop for hanging clothes, or she has to walk, she's working somewhere outside. So dyspnea on exertion is an important symptom,
Right,
which
sir.
should be mentioned.
Yes.
That again indicates the severity of the bleeding.
Yes. So coming to general examination, patient's conscious oriented, moderately built and nourished with a BMI of 24.1 kilogram per meter square. Currently, she's ECOG 2, afebrile at the time of examination. Her pulse was 82, BP was 102 by 58, saturation of 99% on room air, and breath holding time of 20 seconds. On her general systemic examination, pallor was noted, no icterus or pedal edema, no supraclavicular lymphadenopathy or generalized lymphadenopathy. On oral examination, that her tongue was wet and there were no associated mucosal lesions.
In this particular case, which lymph node is more important? Left supraclavicular? Are you thinking?
No, sir, cervical lymph nodes are most
To
important.
say that she has no generalized lymphadenopathy, specifically upper deep cervical. That those are the nodes which are most commonly involved in tuberculosis.
Tuberculosis.
Here, left supraclavicular is not of any importance. We are not thinking of the malignancy.
Right.
And what do you mean by no mucosal lesions? What mucosal lesions?
Sir, angular stomatitis, cheilitis, long
Why
term.
should she have angular stomatitis?
Sir, long term blood loss, anemia.
Long term, 15 दिन का है. Anemia doesn't cause angular stomatitis.
Sir, iron deficiency will.
I think it is vitamin deficiency. It is in prolonged malnutrition. What is more important here? In a patient with GI bleed, what oral examination you are looking at? What are the other less common causes of GI bleed? What are the other lesions? We have discussed ulcers. What else can be there, which has a typical oral mucosal finding, or perioral also. So ulcers can bleed. What else can bleed? What is the commonest cause of rectal bleeding in a child? Polyp. So can this be a polyp disease?
Yeah, but manifesting both decade.
That is later. If you are saying,
so I understood, sir, means if there is any discoloration,
hyperpigmented oral as well as perioral lesions in which condition?
In peat jugars, you can have Peutz jagger. You can have oral pigmentations.
और FAP में होता है?
FAP में नहीं हो. नहीं? FAP में
Peutz jagger. So small bowel polyps, Peutz jagger can cause bleeding. Other than ulcer, polyp will be then becomes malignancy.
Yes.
Isn't it? So that is more important. Yeah.
So coming to her abdominal examination, sir. On inspection, sir, right upper quadrant fullness was noted. The umbilicus was central. No visible peristalsis, cast sinuses or pulsations. No scratch marks in the hernial orifices appeared to be normal. Renal angles and spine were also normal on inspections.
Yeah, Peutz jaggers. Yes, you are right.
And somebody said Meckles.
Meckles. Yeah. Okay. Yes. Dr. Kotecha from Tanzania.
Sir,
but then only thing I would say that yes, we have to keep that in mind. But when a student is presenting a case in the exam, unless it is a child, where you should consider Meckles as the possible. In an adult, it could not be a clinical diagnosis. It may turn out to be that, but it probably would not be a clinical diagnosis because you think of more common pathologies there rather than Meckles.
Sir, on palpation, the abdomen was soft and there was a liver mass which was palpable around 12 into 10 centimeter, hard in consistency, about 6 finger breadths below the right costal margin in the mid clavicular line, and it moved with respiration, sir. The mass the mass was non-tender, sir, and sir, there was no other palpable organomegaly in the abdomen. Sir, on percussion, the liver span, it was percussed in the fourth intercostal space in the mid clavicular line and extended all the way down to six finger breadths below the right costal margin in the mid clavicular line. No free fluid could be percussed clinically, sir. And on auscultation, there were normal bowel sounds that were heard, sir.
So now, since we have confirmed that there is a mass in the liver on our examination, can you put 2 and 2 together? liver mass which has been there for 20 years, and now the patient presents with a GI bleed.
So a large liver lesion may be rolling into uh, very unlikely, sir, because it's such a 20-year-old liver mass cannot.
20 years means that
It's probably
no doubt that this is a benign lesion.
Yes.
So, which benign liver lesion can cause or can manifest as GI bleed, and how? What is the relationship between liver and GI bleed in general? Suppose I say that there is disease in the liver and patient has GI bleed.
Chronic liver disease will manifest as ICP.
No, I'm saying a focal space occupying region or some pathology, focal pathology in liver. Can it cause GI bleed in any way? Not in this case, I'm saying in general.
Post biopsy, they can if there is a bleed. That is one of the possibilities.
How? What is the relationship between any liver pathology and GI?
When it either extends, I mean,
Hemophilia.
Yeah. So that's the only way.
If there's a bleed into the biliary tree, and that will manifest as.
Yeah, but sir, in this case, how can we consider hemophilia?
So, what are the points against hemophilia? Number one, and number two, which liver pathology which has been there for 20 years, most probably benign, will cause hemophilia.
Patient doesn't have jaundice.
There is no history of jaundice. So, what is the classical triad of hemophilia?
The jaundice, GI bleed, and pain. The third pain.
Which pain? Biliary pain.
Biliary pain.
It is biliary colic because of the clot in the common bile duct. Here, there is no jaundice and the pain is not biliary. It is periumbilical. It is small bowel pain. So, unlikely to be hemophilia. And second, hemangiomas, as far as I remember, are not known to cause hemophilia.
They are not.
They are not. So, that is why it is unlikely that the two are related to each other.
On distal rectal examinations, the perianal scale was normal, no sinus, fistula, hemorrhoids. Anal tool was normal with adequate squeeze. The examining finger glove was stained with black stool, sir, suggestive of melena. No palpable mass or nodule was present.
Yeah, so liver mass compressing portal vein and then causing portal hypertension, that is a possibility, but then that will be very CLV. Here we are thinking of a small bowel bleed. So yes, that is a possibility that if there is portal hypertension and that it has caused very CLV. Yes.
So coming to the rest of the systemic examination, it was unremarkable with bilateral air entry equal in the respiratory fields, no adventitious sounds as one as to heard, no murmurs, and there was no focal deficit on central nervous system examinations. So coming to the summary, a 43-year-old female with melena, periumbiliary pain for 15 days, generalized weakness, unquantified weight loss, loss of weight for 10 days, and long-standing liver mass for 20 years, which was evaluated in the form of a needle biopsy bar FNAC around 20 years back, which was suggestive of a benign lesion, and patient is anemic with a large palpable hard liver mass with mild generalized abdominal tenderness and melenic stools on PR examination.
How do you explain the hard liver mass?
Sir, calcifications.
Yes. Most probably there is calcification.
Yes. So now we'll be taking a look at the investigations. We'll be taking a look at her blood work first, followed by two USGs, a triple phase CT and SCOPy, sir. So 18th is the index day of admission at our institute. She was having hemoglobin of 4.5, following which she was, as soon as the 3.9 was noticed, patient then underwent blood transfusion, followed by another blood transfusion on 20th. There was another blood transfusion on 21st. Also, all these values which are increasing in nature are all following blood transfusions. So she has received a total of 5 blood transfusions. She had also undergone an AFP and CA along with the CA19 tumor marker examinations, which were all within normal limits, and there was no deranged liver functions on hematological and biochemical evaluations. Sir, there was a initial ultrasound abdomen done post admission on the 19th. The main finding in this ultrasound was there was a large hyperechoic to mixed echogenic lesion measuring 12 by 15 centimeter in the right lobe of liver and tender under sonar probe with mildly increased vascularity.
What does the ultrasound finding indicate?
Sir, that it's a vascular lesion, about 15 centimeters in its largest dimension. There is some associated probe tenderness, sir. So,
About the nature of the mass. What is the classical ultrasound finding of an hemangioma?
it is hypo. Sorry, it's a vascular. Sorry, hyperechoic. Sorry. Hyperechoic.
Blood there.
Yeah, sorry.
That is what they have seen.
Yes, sir.
It is mainly
Hyperechoic. But
what else you would have liked to know in relation to the clinical findings? What else you would have liked to know on ultrasound?
sir, any associated IHBR or any other?
In relation to clinical finding, why IHBR is related to clinical finding? There was no jaundice. We just discussed hard mass calcification. Calcium can be picked up on ultrasound.
So there was no
have indicated whether it is calcified or not. Yes. Calcification can easily be picked up on ultrasound.
Yeah, so the hyperechoic.
And also the point which was mentioned that whether it is causing portal vein compression. So the delineation of the sphenoportal anatomy, collaterals, spleen, all this can be seen on ultrasound.
So the echoic nature of the lesion on ultrasound is suggestive of hemangioma, but then there is definitely some mention of mixed echogenicity, which may or may not be indicative of hemangioma, sir. So there has to be further evaluation.
Which not suppose there is fibrosis, there is calcification, there is clot formation. I don't know whether all these can cause mixed echogenicity.
So then there was another ultrasound examination done on the 25th, which was showing a 20.5 into 16.5 into 10.3 centimeter lesion in the right lobe of liver extending towards the pancreatic head, compressing.
Okay, so same. It's
yeah.
Hemangioma.
But here, sir, all the more diagnostic of an hemangioma because on the Doppler vascularity was present within, sir, and they had actually considered it a hemangioma, sir. So this is the triple phase CT which was done, sir. This is the arterial phase. So there is a hyperdense lesion, sir, which is primarily located in the right lobe of liver. It is large, sir. There is a uniform arterial enhancement, sir, along with central.
Uniform?
No, sir. In peripherally uniform in the central, there are areas of hypodensity, sir. And however, in these areas of hypodensities, there appears to be central areas of again hyperdensity, sir. So it is suggestive of a non-uniform lesion in the right lobe of liver. Sir, also, sir, if we
is it in the right lobe only?
Also in the left lobe, sir. Now, yeah. So primarily in the
multiple
lobes. And also, sir, if we go back and take a look, sir, the small bowel on the left, sir, if you right here, sir, there is a complex lesion again here, sir, showing internal vascularity, sir. There is a lesion in the small bowel showing internal vascularity and probably some element of calcification, sir.
Right. How can you say calcification on the arterial phase? You have to show the plane cut. So what are the classical findings of hemangioma on a CT scan?
Peripherally enhancing.
Peripheral nodular enhancement. Peripheral nodular enhancement in the arterial phase. That is what you saw. Yes. That it is a irregular. At one stage, it looked like a bilobe mass.
Yes.
Which has dense peripheral nodular enhancement in the arterial phase, and there are central areas of
hypodensity as well as hyperdensity,
and that is why it was seen as a mixed echogenic The small bowel lesion you should describe as a bunch of abnormal arterial vessels seen in, we'll have to see whether they are inside the wall or outside the wall. So most likely a vascular lesion in the small bowel.
So this is the portal face. So the lesion in the liver, there is definitely some washout, sir. There is washout in the
There is
portal.
complete
washout.
complete washout.
Yes. So this sort of typically is suggestive of a hepatocellular carcinoma, sir.
CC is early, very early.
So there is complete, even in the.
I don't know timing. Yeah. And anyway, based on the history, you know that this is not a HCC. What is that big vessel which is seen? Periphery.
It has been pushed, sir. Along with that, even the pancreas has been pushed by the mass. So based on the CT finding, it's an arterially enhancing lesion, sir, with areas of both hyperdensity in the peripheries and in the center, with spaced out areas of hypodensity, along with the mass is big enough to be pushing the portal vein, pushing the pancreas. And other than that, sir, there's also a complex lesion in the small bowel, sir, with vascular lesion, with lot of vascularization along with the lesion, sir. Sir, coming to the triple phase report, the report of this very CT, sir, it is showing a large, well-defined mass lesion of 14 into 20 into 19 centimeter involving segment 4, 5, and 8 of the liver with inferior protrusion into the peritoneal cavity. Shows internal soft tissue and necrotic components. On arterial phase, the scan shows abnormal internal and peripheral vascularity with enhancement of soft tissue components. On portal venous and delayed scan, the lesion shows relative washout of contrast compared to the normal liver parenchyma. No enhancement of in the necrotic component seen. Also, portal venous and delayed scan shows multiple internal dilated and tortuous abnormal vessels. The lesion causes anterior displacement of splenic portal vein and hepatic artery, mass effect on the right, middle, and left hepatic veins. There is no obvious interluminal invasion or thrombosis. Sir, there is no portal vein thrombosis and another heterogeneously enhancing calcified mass lesion on the left side of the abdomen, abutting the proximal jejunal loops, measuring about 3.1 into 3.8 centimeter. No bowel obstruction or abnormal dilatation noted, and large lymph nodes in the retrocaval lesion.
That in the portal phase, they describe abnormal dilated tortuous vessels inside the lesion, which is in the report they say, and I think it was seen also in the portal venous phase. I don't know whether that is typical of hemangioma. Does it indicate an arteriovenous malformation kind of thing? Portal venous phase में भी lesion के अंदर abnormal tortuous vessels दिखता है. They should not be seen in the liver. What was the formal report on the CT? What did they call it?
Sir, on CT, formally they have labeled it as fibrolamellar variant of HC.
They know the history.
Yes, sir.
Yeah, because those vessels are not.
Sir, there are actually a few things in favor of it being a fibrolamellar variant. She's a lady, so that is one. Earlier age, she's in her early 40s. Then also in a non-cirrhotic background.
Yeah, but still 20 years for a fibrolamellar variant without anything.
It doesn't also push, it doesn't invade any of the vessels. The vessels are quite
good. Only point against is the history.
Yes.
I'm not sure whether fibrolamellar variant can go on for 20 years without. So they haven't considered the possibility that it is some kind of a complex hemangioma.
No, sir. Same thing, sir. The impression is also very HCC.
No, but the fact that they have mentioned HCC also means that they probably don't know the history.
Fibrolamellus. They have mentioned fibrolamellus in these. Yes. And complex enhancing lesion with soft tissue and fatty component, as we had discussed. Minimal free fluid in pelvis and retrocable lymphadenopathy. So, along with the other evaluation, she also underwent a UGI scopy on the 20th, which was just suggestive of pan gastritis, and also a colonoscopy, which was showing multiple circumferential aphthous ulcers extending from ascending colon till descending colon, predominantly in the transverse colons, which was suggestive of it being infected. But she has no history of any lower GI bleed from these lesions. So I would like to give a diagnosis of UGI bleed probably arising from the small bowel with an associated HCC, sir. Fibrolamellar variant.
You have to give a pathological diagnosis for the small bowel lesion also. You can't say upper GI bleed from small bowel.
Sir, actually, difficult to classify just based on these assessments, sir.
Doesn't it look like a arteriovenous malformation of the small bowel?
Possible, sir.
This is a vascular.
Actually, sir, even literature these days shows that angiodysplasia is the most common cause of small bowel bleed. Small bowel.
This is not endodysplasia. Endodysplasia
Yeah,
vascular lesion.
Yeah.
Endodysplasia, small lesions. It is the vascular.
It is
This
the
is the arterial lesion. If it is seen in the venous phase, also then probably an arterial.
But will an arterial malformation also have the associated soft tissue enlargement? It looks like a complex lesion. AVM will usually not.
So how would you settle now this issue, whether it is a hemangioma or a fibrolamellar HCC?
I think the best thing would be to do a common tissue biopsy.
Is there any other investigation which can help? Non-invasive?
AFP and all are normal organisms. And ultimately, the diagnosis can only be clinched with treatment. See in such a long.
Check. I think an isotope scintigraphy can, because one is that if you do a tagged RBC scintigraphy, it is quite characteristic of hemangioma. And there is one scintigraphy which is done for fibrolamellar for FNH.
Sir, actually, sir, it will show marking of B12. Fibrolamellar variants. It has B12 marking.
Scintigraphy is there.
It shows B12 marking, so that I'm aware
the
of.
nuclear medicine.
Yes, B12 marking on.
See who else is there in the. Any of the students or faculty would like to comment? I'm not remembering, but I vaguely remember that there is some scintigraphy which can help in delineating either fibrolamellar or FNH. Anybody knows? Any student or any faculty member?
B12 marking of the scintigraphy.
Check. So what will you do?
I would like to do a biopsy. I would like to biopsy the lesion.
Which lesion?
The liver lesion.
Once again.
But her current bleeding said, if we want to know the exact pathology, we can do small bowel enteroscopy.
Okay. Suppose the liver lesion is hemangioma. Then what will you do? Suppose liver lesion is a fibrolamellar HCC. Then what?
So currently her complaints are not related to the liver lesion, and her clinical manifestation is severe anemia. So initially the lesion in the small bowel needs to be tackled. So.
Okay. Another thing, how does it matter? Why do you want to touch the liver lesion if you are not going to handle it?
No, I was just talking about the complete evaluation.
So evaluation is always directed to management.
Yes.
Especially an invasive investigation. The general principle is that you do it only if it changes your algorithm of management.
Yes.
If irrespective of if it is hemangioma, you are not going to do anything.
Yes.
If it is fibrolamellar, then
currently it's a huge lesion. Impossible.
One is that it has been there for 20 years. Second is, even if you want to treat it, is it resectable technically? No. That we will have to see the anatomy now from that perspective. Earlier we were looking at the CT from the perspective of making a diagnosis. Now we will have to look at it from the perspective of resection, which means which segments are involved, which means what is the status, more importantly, of the hepatic veins, not the portal vein and hepatic artery, the hepatic veins. They are the ones which are going to decide whether it is resectable or not.
Yes.
And then, of course, the issue that a lesion which has been there for 20 years, do you want to do that major resection, that complicated resection? Anyway, with a hemoglobin of 4 and 5, she is not at the moment fit for a liver surgery.
Yes.
So that is why you should say that irrespective of what the liver lesion is, currently her problem and her clinical status is because of the GI bleed. That is very easy to target. I will do that first.
Yes.
Let her recover, let her improve, and then decide what is to be done for the liver lesion. If the liver lesion is technically unresectable, then there's no point in doing any other investigation unless you want to say that if it is a fibrolamellar HCC, I'm going to give some systemic treatment.
Technetium 99 sulfur.
Yeah. It is for FNH. Sorry, I knew that there is some scintigraphy which is very specific for one of the liver lesions. I was not sure whether it is.
This shows a B12 surface markings and it takes up that.
Yeah, so maybe B12 tag has to. Thank you, Prof. Potential. Okay, so from a practical management point of view, the liver lesion at the moment, one, it is not treatable. Second, she is not in a condition that it can be treated, even if you want to treat it, or even if you can treat it. So therefore, at the moment, the management would be resection of that small bowel lesion so that her bleeding stops, and then she can be further investigated if required. That also I would do only if it is resectable. I don't know whether any chemotherapy, all these chemotherapies which are, or systemic treatment which are for HCC, are they valid for fibrolamellar also? Because if they are, then yes, you need to establish the diagnosis so that you can give her whatever other treatments are for a unresectable HCC. And actually, HCC is one example of a tumor where all possible methods of cancer treatment can be used, starting from surgery, external radiation, internal radiation, chemotherapy, biological therapy, everything has been used. Interventional radiology. So what will you do for the small bowel?
So there are two ways to look at it. We can actually, since it's ongoing, bleeding is ongoing, and patient is symptomatic for it, we can go ahead and do a resection of the lesions. That is one way of looking at it. So there's another way we want to also diagnose at this. It will be both therapeutic and diagnostic. If you want to evaluate the small bowel, there's an option of enteroscopy. So we can go and.
How will enteroscopy help?
Just
how will it change your management?
It will not. I was just saying, just a diagnostic.
Don't bring such issues. There is a lesion which is bleeding. It has to come out.
It has to come.
So simple. I will do a resection and osmosis of the small bowel. It can be done even laparoscopically. You identify the lesion, make a small incision, bring it out, and do it. Don't. Just because an investigation is available, that way you can say, I will do even an endoscopic ultrasound because it will show me blood vessels there. It's not required. Anybody would like to ask anything or say anything? Dr. Potesha, you want to say something?
Thank you, Prof. No, I don't have any comments, but lesion looks like it is in the small bowel.
Ask or say anything?
We recently had a patient middle-aged.
Thank you very much.